Hi there, this is Richa VJ again. I'm a consult liaison attending at the University of Florida, and today I'll be talking about the consult liaison psychiatry rotation and as an introduction for medical students on interviewing and mental status exam. So what is CL Psychiatry actually? It stands for consultation-liaison psychiatry, also known as psychosomatic medicine. The name recently changed for the official subspecialty. And it is basically psychiatry for patients with general medical comorbidities. So they can have various health conditions that affect the body. It's kind of an integration of psychiatry with the rest of medicine. And so CL can be practiced both in inpatient and outpatient settings, and I've listed a couple of the focus areas, but obviously this is just, there's many more, than these, including like reproductive psychiatry, even like psychiatry embedded into cardiovascular clinics or, endocrinology clinics, surgery clinics. So these are just a few, but you can see like these outpatient clinics can be quite vast. And to become a fellowship trained CL specialist, you do a 1-year fellowship after your 4 years of adult psychiatry residency. However, a lot of psychiatrists actually practice within the field of CL and are not required to have the fellowship. So in terms of your experience here on the CL service, on the inpatient side, we get a number of different consults. So can you think of some of the reasons why we might get psychiatry consults on the CL service? So you can pause the video and try to see if you can name a few. So these are my cheat sheets of what kind of consults we get. So pretty often we have consults for depression and anxiety in patients who are hospitalized for general medical conditions. And this is generally for like both medication management and behavioral recommendations, such as psychotherapeutic interventions. It's kind of up for debate how much psychotherapy is appropriate on an inpatient CL service. And here at UF Shands, we sort of do a more targeted sort of approach where we kind of do more specific tailored interventions over kind of a shorter period of time, just because we're a busy service and don't really have the opportunity to do more frequent sessions. And we use a lot of CBT. That's kind of like the main sort of approach we use. Another reason we might get a consult is for a patient with a history of a psychotic disorder, such as schizophrenia or schizoaffective disorder, and that is generally for medication management, although that could also include behavioral recommendations. Agitation and delirium, that is common in the medical setting, especially in the ICU. Patients who are delirious, which we will talk about a little bit later, that's a kind of a common subject that you'll cover on a CL rotation, is really understanding delirium and how to treat it. Suicide safety risk assessment, so patients who have expressed suicidal ideation will need to kind of come in and assess their safety. Evaluation to determine need for involuntary commitment. That can happen sometimes after people come in with a suicide attempt, or if they have been involuntarily committed out in the community, to determine whether that needs to be continued or not. Sometimes people come in with that and they need to be discharged, so we need to kind of go in and see whether that can be released or not. And involuntary commitment can be both for danger to self, danger to others, or for self-neglect, or kind of the inability to take care of yourself due to a psychiatric illness. Another reason we get consulted are these medically unexplained symptoms or conversion disorder or somatic symptom disorder. These can be very challenging cases because it's really difficult to find the cause of the symptoms, or maybe they can be very varied, not really following a specific pattern of any known condition. Not saying that, you know, these conditions are not, you know, organic and they're purely psychiatric. We just kind of come in and sort of assess those patients and see what we can do. We are kind of like screening them for an underlying psychiatric condition which may be playing a role, while also supporting the primary team in best caring for these patients. And actually, kind of the most important thing in caring for these patients is the relationship between the patient and the team. And if that is a trusting and supportive relationship, the patient will be more amenable to explanations that maybe it's more of a software problem and not necessarily a hardware problem, which is one of the kind of common analogies for these conditions. Diagnostic clarification can be helpful. Sometimes people want us to evaluate for the presence of like an eating disorder, see, you know, if there is an anxiety condition, assess for bipolar disorder, just kind of like various diagnoses. Capacity evaluation, which we'll talk about a little bit more. Capacity referring to the ability to make a decision, medical decision, with a sound mind. Pure psychopharmacology questions we sometimes get. And so seeing as we have a variety of consult types, what must this mean for actual interviews? So as you probably guessed, since we have so many different consult types, the length, style, and approach of our interview is going to vary based on the specific type of consult that we get. And I'm going to go through a few of the most common ones and the general approach to interviewing each patient. So in terms of the consults for depression and anxiety, these consults are kind of like the most sort of like talking consults. So these are the ones where it'll follow most closely to the basic psychiatric interview format, which we'll cover. So it follows kind of like a select set of sections in the interview. So you kind of ask the chief complaint, or you kind of like gauge the chief complaint either by directly asking or by kind of inferring this. And then the HPI, psychiatric review of systems, suicide and homicidal ideation, substance use history, legal history, past psychiatric history, past medical history, social history, and family history. So that's kind of like the basic template of the psychiatric interview. And so I kind of remember this by this crazy acronym, and I actually have created some really embarrassing mnemonic to help me remember that, and I used that all throughout my psychiatric residency to kind of like remember all the sections to the interview. And so this kind of roughly corresponds to all the, or it does correspond to all of these sections. So I would suggest, like, as a medical student, you're going to want to know the basic parts of a psychiatric interview, and you're kind of going to want to know that from memory as much as possible. So try to create your own mnemonic with these letters. I know it might be stupid, it might not make sense, but you know, try to just create something that'll help you remember it. Okay, so here's some more detail into each of the specific sections. And I know this is kind of a busy slide, but just bear with me and we'll kind of go through this one by one. So like I said, the chief complaint, you can either kind of infer that from the patient or ask them directly, like, what are your primary concerns right now? And sometimes they might have a hard time formulating that. So you might have to also sort of decipher that from what they say. And then the next section is the history of present illness, or HPI. And this is kind of like the first part of the illness, where you're sort of like really or the interview, where you really give them the opportunity to kind of have the floor, basically. And you kind of start off very open-ended to really elicit them giving you as much of a story in their own words as possible. And you're listening for main ideas, themes, details about the core problems, while also your focus in this section is like rapport building, and that's a crucial element of any psychiatric interview, where the patient's actually responsive, is to earn their trust, basically. So we can't assume that our patients are going to trust us. That's something we have to earn. And so you earn that trust by listening actively, kind of showing that active verbal and nonverbal listening, and then you kind of express to them that you're understanding them, because that's one thing that patients really want to know, like, does my doctor get me? Do they understand me? So by echoing to them, kind of like paraphrasing in your own words what you're hearing from them, you're going to be building their trust. So that's kind of all happening in the HPI while you're also listening to them to get their story. After you kind of get a general sense of the major themes, and you're kind of asking follow-up questions with the HPI to kind of further uncover elements of the history, you'll move to the psychiatric review of systems. And this is kind of where you are establishing your DSM-5 diagnosis by getting the relevant symptomatology. And there's kind of like a basic framework that you do, and these are kind of like the things that I generally screen for in a CL interview for depression and anxiety. And so the first is like depression, and that, I think every medical student learns the SIGI-CAP mnemonic, and that stands for sleep, interest level, guilt or hopelessness, energy level, concentration, appetite, psychomotor activity, and suicidal ideation. So you want to go through that kind of one by one. And you want to sort of like avoid falling into the trap of being like too checklisty and sort of like rushing to that right in the beginning. You definitely want to start out more conversational. But it is important to kind of understand whether the patient is having these symptoms, because that'll determine the diagnosis. And then for anxiety screening, you want to sort of screen for symptoms of GAD, panic attacks, and OCD. So I'll ask about, like, do you worry a lot? If so, like, what sort of things do you worry about? Do you feel like you carry a lot of tension in your muscles or jaw? That might be a symptom of like stress or anxiety. Do you feel really irritable sometimes? And then I'll always ask, like, are you having panic attacks? And if they say yes, and they might not really understand what a panic attack is, so you might have to sort of describe or define that for them. Kind of like an episode of extreme anxiety or fear, where you'll have physical symptoms, and you're like, your heart may be racing, you may be sweating, and you feel like kind of an impending sense of doom. That might be some way I describe a panic attack. And so you're going to want to like ask them, if they say yes, like about the frequency, timing, the specific symptoms they're having from their panic attack, and those are generally physical symptoms. And then any triggers. So if like a panic attack occurs without a trigger, I think that means it's more likely to be panic disorder. So, and then also OCD rituals can be, I don't always ask about that, but sometimes I do. So OCD rituals can include like excessive hand washing or lock checking. And then mania. So bipolar disorder is one of the most tricky things to diagnose and screen for. But I generally have this framework that kind of helps me out a little bit. And the problem is that a lot of patients with who have been diagnosed with bipolar disorder don't truly understand what having bipolar means. They don't really understand the symptoms of it, and it's kind of like a very misunderstood condition. So that makes it really complicated to diagnose this and to kind of really trust that a patient who's been diagnosed with bipolar in the past actually has bipolar or not. So the way I kind of screen for bipolar is I first start by asking, have you ever been told by a professional that you have bipolar disorder? If yes, in what context? So like, when was that? Who diagnosed you? Where were you at the time? Was it like an inpatient psychiatric hospital? Was it an outpatient clinic? Was it a psychiatrist? Was it a PCP? Was it a therapist? And what symptoms did you have at the time? And the key here is to be kind of like not giving them any of the answers. You're just basically listening to them to hear what did they understand. And you're not kind of shouting out the typical symptoms just yet, because you don't want to put like words in their mouth. You want to hear directly from the source what they understand. And then after I ask that, I'll kind of follow up and say, have you ever gone a week without needing to sleep and still had a lot of energy? And then I'll be a little bit more specific and say, have you ever had a period of time of 4 days to 1 week or longer when you required little sleep and were feeling excessively happy to the point you were behaving in ways that were uncharacteristic for you or engaging in risky behaviors? So that's kind of a mouthful. And a lot of times patients might not like fully like that sink into them, and they may say yes to that. So then again, I'll say, if yes, tell me about that time and what was going on. And you want to like actually listen really closely. Does what they're saying actually sound like bipolar, or does it sound like something else, like a personality disorder or something? And then after you do that, then you kind of go into the dig fast symptoms. So once you ask them, like, tell me about that time, and then you say, thinking back to that time, like, did you have distractibility? Did you have insomnia or irritability? Did you have grandiosity? Did you have flight of ideas? Did you have increased activity? Did you have sleeplessness? And were you more talkative? And then we kind of move on to psychosis. So, you know, you can ask about auditory hallucinations, visual hallucinations, paranoia, ideas of reference, which are kind of like I described to the patient as like TV referring to you specifically, or really like odd coincidences happening in the world that you think are somehow conveying a special meaning to you. And you can ask about thought insertion, thought broadcasting, and really like how detailed you get with this section sort of depends on the situation. So I'll generally always ask about AVH, but I won't necessarily like ask all the rest if it's not really relevant. And if they do say yes for auditory or visual hallucinations, you want to follow it up with like, what do the voices say, or what do you see? And then sometimes I'll screen for trauma as well, and I'll kind of benchmark it with the fact that, you know, this is a CL interview, and you know, we don't necessarily need to go into the details or specifics and rehash all of your past traumas right now. But I am curious to know, like, have you ever experienced an event which you consider traumatic, such as an abuse of physical or emotional or sexual nature? Any near-death experiences that were traumatic, or like really like anything traumatic that you remember? Because sometimes what the patient experiences as traumatic could still be leading to PTSD or trauma symptoms, and yet like it might not be actually kind of a DSM diagnosable trauma, but it doesn't really matter in my opinion. And this can be really relevant in cases of like conversion disorder or personality disorders. Those are kind of situations in which knowing a trauma history is particularly important. And then the rest of the interview, so suicidal and homicidal ideation. I start off with asking more passive questions like any thoughts that you would rather not be alive or that you would like to go to sleep and not wake up. Have these thoughts, and you kind of follow it up with like more active symptoms and say, have these thoughts progressed to actual plans or how you would harm yourself, for how you would harm yourself. Have you taken any action on these plans? Are there any guns at home? Where do you keep your guns? And honestly, like if you live in a place where there's a lot of guns, you might just go straight to like, where do you keep your guns, to sort of avoid stigmatizing the patient when you kind of assume that most people probably do have guns, and they kind of look at you funny, like, why are you asking me a semi-dumb question? So you just kind of gauge that based on your area. And from the SIHI questions, you're really assessing safety, and that kind of helps you determine how much into like a suicide safety risk assessment you need to be doing. And then getting into substance use history, you start off with the least stigmatized substances, and then you kind of go into the more stigmatized substances. And you always benchmark this by saying like, it's always a standard question to ask about substance use history that I ask every patient. So you can ask, and there's multiple ways of like phrasing these questions, but I just kind of ask it this way, like, do you smoke cigarettes? How many cigarettes per day? Do you drink any alcohol? How much? How often? What type? If heavy use, ask about history of alcohol withdrawal, shakes, seizures, or DTs. And then like I start for illicit substances, I start off with marijuana. Do you use marijuana? A lot of times people don't really consider that an illicit substance, so I kind of separate that from the rest. Any other drugs like cocaine, meth, opioids, or party drugs, and you kind of want to list them all out, not like, or like at least some of them, to kind of like explain what you mean by that. And then if they are kind of have a history of substance use or currently using, you can ask about their longest period of sobriety and any history of going to drug or alcohol rehab. Legal history, I just kind of very simply ask, like, are you currently experiencing any problems with the law? Past psychiatric history, I'll assess for prior psychiatric diagnoses, past or current medications, past or current outpatient psychiatry or therapy, history of suicide attempts, cutting, or violence, prior psychiatric hospitalizations. Past medical history, just kind of like their other comorbidities. You want to know sort of like what other medications they're taking, which could potentially interact with your psychiatric medications. And on the CL setting, it's really important to know if there's kind of renal disease or cardiovascular disease or any other liver disease or any other diseases that could impact our doses of medications or which medications we're choosing. Social history, I'll ask about occupation, marital status, children, living situation, highest education. And family history, assessing for any psychiatric diagnoses that are in the family, substance use, medications for psychiatric reasons, and suicide attempts. So yeah, moving on, the next disorder that we'll talk about the interview for is this history of psychotic disorder. And you'll probably quickly see that the interviews for these patients are much different sometimes than the ones that you'd use for the depression and anxiety interview. And it may be more difficult to get a complete history from the patient due to various reasons. They may have a more disorganized thought process. They may actually have cognitive impairment, and they might have some delusional ideas that interfere with providing an accurate history. So collateral sources, or like talking to the family, loved ones, friends, or other treatment providers, are an important part of obtaining the rest of the history. Also, obtaining prior medical records can be helpful. And you start, like with your actual interview with a patient, you kind of tend to like ask more straightforward questions, like understand how they understand their admission, their degree of insight into the situation, And you always want to understand like what's their baseline level of functioning, which will help you determine whether this person needs to be hospitalized or not. Because if they're sort of at their baseline and they're sort of stable, even if they might be having some symptoms, they might not necessarily need a psychiatric admission. And you want to get through, you want to attempt as much of your basic psychiatric template as you can for these patients. Although you have to know to kind of shorten it or curtail it or kind of ask more focused questions when kind of like you're getting the sense that the history you're getting is unreliable. For agitation and delirium, it may be very difficult to interview these patients at bedside. And there's both hyperactive and hypoactive delirium, which may both be difficult to interview. The hyperactive patients may be too agitated to cooperate, while the hypoactive may not be aware enough to really communicate. So you're going to try to ask like simple questions, if you can ask questions at all. Their understanding of the admission, any hallucinations or paranoia, anxiety and distress, physical pain, any symptoms, and basically anything else that you're able to obtain from the regular template. And then you're going to sort of assess cognition. The most kind of notable feature that's altered in cognition for patients with delirium is attention. So to test for that, you can use the months of the year backwards, like asking them to say that, or the days of the week backwards. There's like multiple screening assessments that can be used, like the CAM or the confusion assessment method and the CAM ICU, which kind of walks you through the screening process for delirium. And then you'll probably do like more of a physical exam than you might otherwise do in other patients, doing a visual inspection, looking at their monitor for their vital signs, seeing if there's any hypotension or tachycardia or fever, respiratory abnormalities, looking at their lines and drains, checking for involuntary movements, frontal release signs, kind of measuring their Glasgow coma score. They're checking for reflexes, possibly doing like a Luria sequence, which is kind of like testing the frontal lobe's control of hand motions. And then, you know, it's important to get collateral for these patients as well from the nurses, from the primary team, and from family and friends. And you want to know sort of when did the altered mental status or the delirium begin? Were there any medical events near that time, such as new medications, procedures, or anesthesia? What is their baseline cognition like? Do they have a history of dementia or cognitive impairment? Do they have any medical comorbidities? And what kind of recent symptoms were they having? And, you know, you'll try to get as much of the rest of the interview from the collateral source as well. You're always going to want to review their medication list, looking for anticholinergic or deliriogenic meds, and there's many lists online of like all the medications that can be associated with delirium, and it's quite extensive, the list. But really, what's more kind of suspicious is if medicine was just recently started that seems to coincide with the onset of the delirium. That's kind of more of a clue that that might be related. And you want to kind of sort of assess for common causes of delirium. And useful mnemonic is the I watch death mnemonic, although literally like so many different things can cause delirium that you know, you just might have to think pretty broadly. The suicide safety risk assessment, you'll need to assess for both passive and active SI, plan and or intent. The Columbia Suicide Safety Rating Scale is a helpful way to kind of go through and assess suicide risk. And you'll want to assess for risk factors and protective factors for suicide, and the safety suicide risk stratifier can be a helpful tool for that. It kind of goes through the various risk and protective factors and helps you estimate suicide risk. You'll need to assess the need for involuntary commitment when there's a risk of imminent harm to self or others due to psychiatric illness. And you'll get details on recent stressors, what's driving them to feel suicidal. Is this more of a chronic SI, like are they kind of chronically suicidal and this is not really like anything new? They could be a function of like a personality disorder such as borderline personality. Have they had past suicide attempts, which is kind of like the biggest risk factor for future suicide attempts. And you'll want to get through as much of your basic template as well as you can. For the capacity evaluation, so capacity, like I said before, means that you have a sound mind needed to make a medical decision. And you need, when you get a capacity consult, you always want to know what is the specific decision this capacity evaluation is for. Is it capacity to leave AMA, to refuse a procedure, to refuse placement into a rehab or a nursing home? So you want to know exactly what you're assessing for. And the 4 elements of demonstrating capacity is kind of remembered by the mnemonic CURA. So they have to have a clear and consistent choice for their decision. They have to demonstrate understanding of the medical information, such as what are the proposed treatments, what are the details of their illness, what are the risks and benefits of the proposed treatments. They have to demonstrate a logical reasoning in making their decision. So their reasoning doesn't necessarily have to be a reasoning that you agree with, but it has to be logical. And they have to appreciate the consequences of their decision. So capacity exists along a spectrum from low stakes decisions to higher stakes decisions. And the higher the stakes of the decision, the more they need to adequately demonstrate all 4 aspects of CURA. So if they kind of just want to refuse a blood draw, which is not really that important for their medical care, and they don't really like clearly show all of CURA, maybe they have a dementia or cognitive impairment. Would it really be worthwhile to stick that patient or like put them in restraints to get that kind of inconsequential blood draw? Probably not. So we wouldn't really need them to demonstrate all of CURA. However, if they were trying to refuse a life-saving procedure, then they would probably need to show more of CURA. So it's helpful when you're getting the consult to ask the primary team about the risks and benefits of the relevant decision and the proposed treatments. And if it's a really complex situation, ask them to be present. You need to know the risks and benefits of the decision so you can assess if the patient understands it. Because if you don't understand it, how can you know if the patient understands it? So that's why you really need to get the primary team to explain it clearly to you. Sometimes you may need to get ethics involved, and once you determine that a patient lacks capacity, you need to have sort of a plan about how you would approach it. And you always kind of want to get a surrogate decision maker involved, the legal next of kin or the guardian, to help you in making the decision that would be in the patient's best interest and demonstrate what they would have wanted for themselves if they did have capacity. And so when you're doing this consult, you do focus most of your interview on the capacity question, but you want to briefly review some of the other elements from the psych template just for the documentation purposes. And for the last slide, I just wanted to cover some basics on mental status exam, which is an important part of like the oral presentations you may do on psychiatry as well as in your documentation. So these are kind of like some of the basic sections of the mental status exam, although some templates might include it slightly differently. So the first is appearance. Those listed there are some of the things you might assess for. When I'm kind of like writing a note, I'll sort of indicate whether they appear their stated age, younger or older than stated age, and I'll comment on grooming and hygiene, whether they're disheveled or appropriate. You can also comment on eye contact, like what they're dressed in, whether it's hospital attire or casual attire, how their attitude towards you, any tattoos or prominent physical abnormalities. You might also comment on like lines and drains or like other medical apparatus. Motor, you'll kind of talk about like any abnormal movements such as tremors or tics, kind of talking about gait if you do observe their gait. Speech, you want to comment on the rate, rhythm, volume, amount, articulation, and spontaneity. So the things I might include are whether the speech is fast, slow, low or loud volume, limited spontaneous speech, or hyperverbal. Affect is kind of like what you interpret as sort of like their emotional state from based on their physical appearance. So some words that I might use would be like withdrawn, dysphoric. I use dysphoric for when they look tearful and sad. That goes along with depression. Anxious, elevated for patients who look a little bit hypomanic. Irritable, those are common words I use for affect. And if you kind of Google affect terminology, you can probably find some lists that have like a bunch of more affect terms. And then it's not listed here actually, but the relevant related section to affect is mood, which is what the patient understands as their emotional state. So it's kind of like in their own words what their emotional state is. And you usually put that in quotation marks. So that could be like depressed, anxious, irritable, like all basically kind of similar words, but it's what the patient describes their mood as. Thought content, you can include like suicidal ideation, homicidal ideation, any particular themes that they kind of reference repeatedly, any paranoid ideations, delusions. Thought process refers to how well the patient's ideas link together, and if it's kind of logical and it makes sense, or if it's more disorganized and disjointed. So words you might use for thought process include linear, tangential. Tangential meaning you ask them a question and they kind of go on a tangent and sort of like lose track of what was asked and get kind of sidetracked and talk about something else. Circumstantial is when they include excessive detail and kind of take a circuitous, long-winded way of like kind of leaving what you asked and then kind of coming back and finally answering the question. Disorganized is just a general term that encompasses, tangential and circumstantial. It can also include like looseness of associations, which is when like the ideas kind of don't clearly link together. Poverty of content is when there's just like very limited ideas. And word salad is like the most severe type of disorganization where like it's totally disjointed. They're just individual words that don't make any sense together. Perception, you'll include like presence of hallucinations. Intellect is kind of like your global impression of their intelligence. And insight and judgment, insight refers to their awareness of their illness, how well they understand their diagnosis and their symptoms, and that they do have a psychiatric condition. Judgment is kind of like your assessment of their judgment, and that might be related to kind of whether you feel like they're taking like responsible actions or if they're acting in poor judgment. And you'll kind of like indicate both insight and judgment as either poor, fair, or good. And you'll want to include a sentence for like why you've chosen that. Okay, so that was a brief review of the psychiatric interviewing on the CL service. I wish you all the best for your time rotating with us, and I hope you learn a lot. Okay, take care.